everyone. My name is Udaipurwala. Today, I'll be presenting my research on data-optimized adaptive cognitive stimulation therapy to promote enhanced neuronal function in geriatric dementia patients through the use of subtype-specific interventions. A little introduction, I'm a rising junior at Shrewsbury High School in Shrewsbury, Massachusetts, with an interest in neuroscience and cognitive brain sciences. I have research experience in the field of neuroscience where I'm working with Dr. Patrick Emery, studying the effects of controlled neuronal gene expression in Drosophila melanogaster, which are fruit flies, on the functional rescue of protein aggregates in Alzheimer's disease to see if gene expression can break down protein aggregates causing Alzheimer's disease. Additionally, I'm working with Dr. Sivakarthik Varanasi at UMass Medical School again, where I'm studying the effects of metabolic T cell adaptations for early diagnosis of malignant cancers in the liver and pancreas. Essentially, what dementia is it's the symptoms associated with cognitive decline that interfere with a patient's daily life, including things such as their memory, thinking, and sociability. Common symptoms of dementia include memory loss, which over 90% of dementia patients suffer from, communication difficulties, disorientation, among other symptoms. My program identifies four different types of dementia: Alzheimer's dementia, vascular dementia, which is dementia that occurs after a lack of blood flow to the brain, Lewy body dementia, which is dementia that occurs as a symptom of Parkinson's disease, and frontotemporal dementia, which is dementia that occurs after severe deterioration of the temporal lobe in the brain. So what we see in the year 2025, there's over 60 million cases of dementia, 43 million of which being in low to middle income countries, and 26 million being in high income countries, such as the United States. So, to do the data optimization in this project, I used four different data sets, with one Alzheimer's data set, one frontotemporal data set, one Lewy body dementia data set, and one vascular dementia data set. We implemented these data sets into a neural network. And essentially what a neural network is, it's a computational system that assesses patterns found in pictures, in this case, the brain scans from each data set, and sorts them into supercategories. So I sorted them into two different supercategories, healthy and dementia-induced. And these were found through assessing the different patterns, corners, colors, and shapes found in each of the brain scans. In the dementia-induced category, I sorted into four more subtypes for each one of the four dementia types: Alzheimer's, Lewy body, frontotemporal, or vascular, meaning that there's four different treatment intervention plans for each type of dementia, which a different patient can use based on the severity and the type of dementia which they have. For the results, this graph is a class separation and probability distribution. How we evaluate a class separation distribution is by looking at the kernel density estimate, which is the smooth curves that you can see right here that show probability distributions. And then we look at the positive and negative classes, which are the blue and the red. These classes represent the cases where the model accurately resolved whether a patient had dementia, what subtype they had, and then further displayed accuracy by giving them a difficulty adjusting stimulation therapy method based on their specific subtype of dementia as an intervention. So why is this probability distribution statistically significant? So good class separation means that there's minimal overlap. So the distribution overlap right here, and in the graph, the overlap is this dark blue section. So our distribution overlap is 0.1477. The closer it is to zero, the closer it is to perfect separation. And the closer it is to one, the closer it is to identical separation, which is what we don't want. And this is because it's easier for the machine learning model to accurately discriminate rules that show the decision boundaries, in this case, the healthier dementia-induced classes. So the 14.77% overlap quantifies that there's 14 out of 100 ambiguous cases which need further screening. But this likely means that the patient is healthy and they're not able to find proper mentions of specific patterns found in dementia-induced brain scans. So this is clinically actionable because it balances sensitivity along with specificity at 83% and 87% respectively. So the true positives, which are the dementia cases, is 83% density. This means that 83% of cases are accurately categorized into their respective types, reducing delay to create appropriate interventions, and 87% specificity, which is the true negative class or the healthy class. And this means that it avoids unnecessary interventions for 87% of healthy patients. 5 key takeaways/global impacts which can be taken from this project. First, it's that computational optimization enhances cognitive intervention efficacy. Data-driven adaptations improve memory outcomes while reducing session duration. This can be seen through both of the graphs from the results section, which show that the model properly distinguishes between healthy and dementia-induced patients in the subtype of dementia which they have, creating a treatment plan in interventions to help them with their symptoms before they are completely deteriorated by their dementia and protect them from further deterioration. Secondly, it's that early decline can be predicted and protected using computers and computational optimization. Key behavioral and cognitive signals allow for proactive intervention. This can be seen through the use of a neural network which finds patterns between the brain scans of all patients, showing that the model will accurately distinguish patients based on their brain scans and their symptoms to give them proper interventions to help with their specific type of dementia. Third, it's that personalization maximizes treatment effectiveness, showing that difficulty adjustment, tailored protocols, and separate types of answer responses through the use of typing, speaking, or touch patterns can outperform one-for-all approaches across all dementia subtypes. Fourth, it's that large-scale treatments which use computational models and clinical data sets can allow for local and global usage of easy-to-use and reliable computer cognition therapies. This allows for greater access, which goes into point 5, to cognitive stimulation therapy and dementia treatments worldwide. It's a cheap and effective treatment method which can be used for anybody in any part of the world. Thank you for listening. My email is udaipurwala@gmail.com, so if you have any questions, feel free to reach out.